for your introduction, and I would like to thank Pierre Farb for sharing this symposium with us and sponsoring the program. And actually, they were very smart to choose to have the right choice in the right time of choosing oral chemotherapy in the time of COVID-19. So shall I shift? As all you know, we daily following the number of deaths and infection occurring to the population worldwide. Now we exceed 20 million persons have been affected with COVID-19, and we have more than 600,000 deaths. This presentation is focusing on two parts. The first part will be given by, should be given by my colleague, Professor Abdelaziz Bilal, about the use of oral chemotherapy, navilbine, in non-small cell lung cancer. And my part is the efficacy of navilbine as oral therapy in first-line metastatic breast cancer. As a single agent, when compared to taxane in first-line HER2 negative metastatic breast cancer, this trial randomized patient who has confirmed locally advanced or metastatic breast cancer, no prior chemotherapy, ER positive, presented pre-treated with hormonal therapy, and they are HER2 negative. With Karnofsky performance status more than 70%, and they were randomized to either oral navilbine 80 milligram per meter square weekly, day 1, 8, and 15, or paclitaxel 80 milligram per meter square, day 1, 18, 8, and 15. And the primary endpoint were disease control rate, and the secondary endpoint were safety and quality of life. 3 weekly cycles, first-line chemotherapy till disease progression, and accrual completed with a sample size of 131 patients. And first results submitted to San Antonio Breast Cancer Symposium in 2017. As you can see, the both arms were quite balanced, and please notice that both arm patients receive at least 2 lines of prior hormonal treatment. And what is interesting is that there was no difference at all between the time to treatment failure and progression-free survival. A little numerical benefit in favor of oral navilbine 80 milligram per meter square. What is also interesting was hematological, with tolerance of the patient with grade 1, 2, 3, and 4 toxicity, quite comparable between the two arms, and for non-hematological toxicity were in favor of the oral navilbine, especially alopecia and peripheral neuropathy. Patients treated with oral navilbine have less cumulative toxicity, especially alopecia and neuropathy, and which usually need a longer time for treatment and overcome these complications. The NORCAP trial CA223, we have the final results of randomized phase 2 trial comparing first-line first-line oral versus taxane-based chemotherapy for HER2 negative metastatic breast cancer. It was published in 2016, and there was no difference actually between oral navilbine in combination with capecitabine, or gemcitabine combined with paclitaxel, or gemcitabine combined with docetaxel. The overall response rate was numerically better with the oral chemotherapy, 33% compared with 24 and 50%, no significant difference. And the disease control rate was 73% in the oral chemotherapy, 78% in the gemcitabine paclitaxel, and 80% in the gemcitabine docetaxel. The overall survival was not different between the three groups significantly, and oral nevilbine and capecitabine as effective as vaccine-based regimen and offer the advantage of only full oral treatment. What about hematological toxicity? The hematological toxicity was quite in favor of the oral nevilbine and gemcitabine, with only 18% of the patient need GCSF support, and compared with 40% of the patient in the gemcitabine docetaxel arm. What is the more interesting is the percentage of the patient who get alopecia. About 76% of the patient in the gemcitabine docetaxel arm, compared with only 8% in the patient with the oral chemotherapy, which is quite impressive. Other toxicity were quite comparable. This randomized multi-center study in HER2-negative metastatic breast cancer previously treated with anthracycline in first line. The patient were randomized into 3 arms, equal distribution. This patient has confirmed HER2-negative advanced metastatic adenocarcinoma with prior treatment with anthracycline, chemotherapy naive in metastatic setting. Prior hormone therapy is allowed, up to 2 lines of prior hormone therapy with good performance status. Patients were randomized to oral nevilbine 80 mg per meter square day 1 and 8, and plus capecitabine day 1 to 14 every 3 weeks. Oral nevilbine 80 mg per meter square day 1, 8 and 15, alternating with every 3 weeks with capecitabine 1000 mg per meter square BID day 1 to 14. Or docetaxel 75 mg per meter square day 1 plus capecitabine 1000 mg per meter square BID for 14 days. And the endpoint, the primary endpoint, were disease control rate more than 3 months, and secondary endpoint were safety, overall response rate, progression-free survival, and time to treatment failure. And finally, overall survival. Chemotherapy were administered in 3 weekly cycles until disease progression or unacceptable toxicity or patient withdrawal from the study. And here the results. The primary endpoint, disease control, were comparable in the 2 arms of docetaxel capecitabine compared with docetaxel nevilbine plus capecitabine, with overall response rate around 30%, compared with oral nevilbine then alternating with capecitabine about only 9%, and this less than half. So this arm should be withdrawn, and we can't compare with this alternating regimen. The median progression-free survival was 8.9 months in the docetaxel capecitabine arm, compared with 7.2 months, and median time to treatment failure was 4.3 months compared with 5.6 months. The median overall survival was 24.2 months compared with 22 months. So oral nevilbine plus capecitabine is as effective as docetaxel capecitabine and offers the specific advantage of only all-out combinations or oral combination as an outpatient treatment. When we compare the toxicity, navilbine oral plus capecitabine versus docetaxel plus capecitabine induce less neutropenia, febrile neutropenia, infection, hand-foot syndrome, and alopecia. And this was clear in all the toxicity that was recorded, especially grade 3 and 4 toxicity. So oral navilbine in HER2 positive metastatic breast cancer, navilbine plus trastuzumab as a reference regimen with best synergistic combination index. So we can consider synergistic if the combination is more than one, additive if the combination is equal to 1, or antagonistic if the combination is less than 1. So for navilbine, the combination was quite impressive with 0.35, the docetaxel 0.41, and the cyclophosphamide was 0.57, compared with doxorubicin, paclitaxel, iberubicin, and the antagonistic were in the methotrexate, gemcitabine, and fluorouracil combination. So, taxane plus trastuzumab compared to oral navilbine plus trastuzumab in HER2 positive metastatic breast cancer. The endpoint, the primary endpoint were progression-free survival, and the secondary endpoint overall survival, response rate, incidence of brain metastasis, and brain metastasis-free survival. This was published in Breast Care in 2014. Starting oral navilbine plus trastuzumab in first line for patient with HER2 positive metastatic breast cancer as induction trastuzumab 4 then 2 milligram per kg weekly, or 8 then 6 milligram per kg every 3 weeks. The primary endpoint with progression-free survival, secondary endpoint were overall survival, overall response rate, and incidence of brain metastasis or brain metastasis-free survival. For the oral navilbine, 60 or 80 milligram per meter square, day 1 to 8, and compared with docetaxel every 3 weeks, or docetaxel weekly, or paclitaxel weekly, or paclitaxel every 3 weeks. So the disease free interval more than 2 months with 42% in the navilbine arm compared with 30% in the docetaxel or paclitaxel arm. And the visceral metastasis was only 65% compared to 75%. Adjuvant previous chemotherapy were given in 63% in the navilbine arm, 55%. Adjuvant taxane-based regimen was 27% in the navilbine arm compared with 8% in the taxane arm. So it was slightly in favor of the taxane arm. Look at the response rate. 15% complete response compared with 2.8%. The partial response were 47% compared with 58%. Overall response, not significant, 62% compared with 61%. Stable disease, 17 compared to 16, and disease control, 80 compared to 77%. So, navilbine, oral navilbine plus trastuzumab as a potentially viable alternative to taxane, offering median survival of 5 years in first-line metastatic HER2 positive breast cancer. So, as a patient were treated with trastuzumab compared with navilbine, as I mentioned before, the same regimen. The incidence of brain metastasis with not significant, 40 compared to 55% in the taxane arm. And time related to parameters, median follow-up was 47.5%. The brain-free metastasis was 69% compared with 51% in favor of the navalbine arm, with quite significant p-value was 0.03. Progression-free survival not significant. Median survival was significant in favor of the navalbine arm, 57 months compared with 48 months. What about the tolerance? The dose reduction due to treatment-induced toxicity only observed in 15% compared with 30% in patients who had been treated with taxanes. This more than half of the need of the number of the patient who need dose reduction because of toxicity. This results add to the growing body of evidence that navalbine is a viable alternative to taxane as chemotherapy backbone for trastuzumab containing chemotherapy or immunotherapy regimen. So it is could be a good alternative or good choice as first line HER2 positive metastatic breast cancer. Oral navalbine, a recommended therapy in metastatic breast cancer. The guidelines from the start. For the ASCO guidelines, there is no gold standard for the chemotherapy in metastatic breast cancer. There is no ideal strategy. The treatment is determined by factors such as disease subtype, drug toxicity profile, patient preference. The chemotherapy should be individualized and based on the previous treatment and the treatment objective. The ABC recommendation options are available and effective, such as capecitabine and navalbine, particularly if avoiding alopecia is a priority of the patient. And interestingly, when you practice, you see that alopecia is a real issue for many women with metastatic breast cancer. In patient pre-treated in the adjuvant or metastatic setting with an anthracycline and taxane and who don't need combination chemotherapy, single agent capecitabine or navalbine or eribulin are the preferred choice. For first-line therapy, when trastuzumab is used as solo anti-HER2 agent, the preferred agent are navalbine or taxane. When dual blockade with trastuzumab and brituzumab is used, possible agent to combine docetaxel, paclitaxel, vinorelbine, nab-paclitaxel, or capecitabine could be a choice. These are the NCCN guidelines, last version, and they recommend navalbine as a preferred regimen among the different combinations in HER2 negative breast cancer. Again, also in HER2 positive breast cancer, it is among the guidelines of the NCCN in HER2 positive metastatic breast cancer. So the recommended schedule in metastatic breast cancer, navalbine oral as a single agent, 80 milligram per meter square weekly after 3 doses at 60 milligram per meter square to test the patient's susceptibility to neutropenia. So we start with 60 milligram per meter square, then for 6 weeks, then we upgrade to 80 milligram per meter square as far as the patient relating, and there is no major problem with the neutropenia. For the combination, navalbine oral 80 milligram per meter square day 1 and 8 combined with capecitabine 2000 milligram per meter square per day 1 to 14. This is a 4 weeks cycle, as usually at the first cycle we give 80 milligram per meter square to patient susceptibility to neutropenia. When combined with trastuzumab in 3 weeks cycle, navalbine oral 60 milligram per meter square day 1 and 8, or with trastuzumab induction dose 8 then 6 milligram per kg day 1, every 3 weeks. After first cycle, usually we start with 60 milligram per meter square to test the patient's susceptibility to neutropenia. This is how the drug available. We have 20 and 30 milligram capsules, and these capsules, as you can calculate, the 80 milligram per meter square patient, if the patient's average patient usually 1.7, he will need one of the 20 milligram per capsule and 4 of the 30 milligram capsule. If the patient is on the 60 milligram per meter square, the average patient, you may take 2 of the 20 milligram per meter capsule and 2 from the 30 milligram capsule. Instruction about the taking the medication. Nabilbine oral capsule should be swallowed with a glass of water. Usually you have to avoid warm beverages because it is a gel. It has a gel content, so it is quite sensitive to hot beverages. At the end of a light meal, you have to use antiemetic prophylaxis about 30 minutes or to 1 hour before nabilbine oral intake. Patient must not crash or suck the capsule. As I mentioned, it is a gelatin-containing capsule. In case of vomiting, never repeat drug intake. Wait until the next intake planned. So this is the summary of international COVID-19. This is what we should do during the era of the COVID-19. The approach of cancer patient must be dynamic, tailored to every patient condition, every hospital resources, every physician experience, keeping in mind that new guidelines are being continuously issued by international and national authorities. Therefore, stay tuned, because as all you know, we change our recommendation day by day regarding the handling a patient with COVID. Oncologists must keep in mind that COVID-19 outbreak extent and the risk of unavailability of high-level care in oncology would be greater than that of COVID-19 infection in a cancer patient. This for sure. Re-evaluating regimen schedule to reduce the number of clinic hospital visits during the pandemic, 3 or 2 weeks as opposed to weekly, oral or subcutaneous alternative as opposed to intravenous administration should be encouraged. Some anti-cancer drugs conventionally administered through infusion were changed to oral administration drug if possible, such as etoposide, vinorelbine. Individual undergoing adjuvant chemotherapy or maintenance chemotherapy had their infusion interval appropriately prolonged, dependent on the condition of the individual patient. In metastatic breast cancer, when utilizing chemotherapy preference, should be given to oral agent and agent with lower risk of immunosuppression. Vinorelbine can be used in its oral formulation as a dose reduction and can be considered to avoid hematological toxicity. So the take-home message: oral nabilbine is the preferred chemotherapy to start with in patients with first-line metastatic breast cancer. A listed preferred choice in the recent published literature related to cancer patient management during COVID-19. It is as effective as taxane in monotherapy or combination in HER2 negative metastatic breast cancer. The potentially valuable first-line alternative to taxane when treating HER2 positive metastatic breast cancer. It is recommended by international guidelines, NCCN, ASCO, ESMO, San Antonio Breast Cancer Conference. Manageable safety profile with rare cumulative toxicity allowing longer treatment for better outcome. And I think I finished my part. I